Hello everyone. Today I'll be starting a revision session for MRCP, and basically it'll involve all the systems that are there, starting with cardiovascular system. And this is basically the book called "The Only MRCP Notes You Ever Need," fifth edition. So I'll just revise through it. Hope you like and revise with me. So cardiovascular system, firstly, it comprises of the physiology, um, the myocardial action potential that's there. So firstly, the thing you need to know is basically the phases of the myocardial action potential. You see that the phase 0 is rapid depolarization. So it's basically rapid sodium influx. This is what happens when sodium gets in, and that's why there's this moving up, the depolarization of the myocardial cells. These channels automatically deactivate after a few milliseconds. Phase 1 is basically repolarization when potassium moves out of the cell. This is the phase 1. And there is a plateau phase in between when calcium gets in and potassium gets out, but then calcium gets in more rather than the potassium going out. And phase 3 is when this repolarization, the proper final one, is efflux of potassium. That's when it goes down. And so this is the whole thing. And the fourth stage is the restoration of ionic concentration when the the cell goes back to its normal condition, that is resting potential, is stored by sodium potassium ATPase. This is what helps the cell go back to its original potential. There is slow entry of sodium into the cell, decreasing the potential difference until the threshold potential is reached, triggering a new action potential. So this is the whole thing. Cardiac muscle remains contracted 10 to 15 times longer than skeletal, so of course that's why it's stronger. The next thing that comes up is atrial conduction. Atrial conduction is basically what we need to remember is the speed. The speed is 1 meter per second, and that's written here. Spreads along ordinary atrial myocardial fibers at 1 meter per second. AV node contraction is 0.05 meter per second, and ventricular conduction, AV node is slower as you can see, and ventricular conduction, Purkinje fibers are of large diameter and achieve velocities of 2 to 4 meter per second. That's faster. This allows a rapid and coordinated contraction of the ventricles. Okay, next thing comes up is cardiac physiological changes during exercise. So during exercise, what really happens? That's the question. Blood pressure, systolic blood pressure rises and diastolic blood pressure lowers. So there is an increase in pulse pressure, the difference between systolic and diastolic. In healthy young people, there is increase in mean arterial BP, but it's only slight. Next is the cardiac output. Cardiac output increases in exercise, that is 3 to 5 fold, not more than that. Why is it happening? Results from venous constriction and vasodilation and increased myocardial contractibility, as well as from the maintenance of right atrial pressure by an increase in venous return. So all these things are causing an increase in cardiac output. Heart rate increases by 3 fold, and stroke volume up to 1.5 fold. So we all know that cardiac output is the product of stroke volume and heart rate. So all these are increasing, so definitely cardiac output will increase. Ejection fraction is a measurement of how much blood the left ventricular pumps out with each contraction. Normally 60 to 70% of the total amount of blood in the left ventricle is pushed out with each heartbeat. So 60 to 70% is what's normal. So there's a formula for it: stroke volume by end diastolic volume into 100%. And stroke volume is end diastolic volume minus end systolic volume. That is the volume left at the end of diastole minus the volume at the end of systole is stroke volume. That is the amount, the volume ejected. The next topic is also very important: the jugular venous pulse. What's here? Okay, as well as providing information on right atrial pressure, the jugular vein waveform may provide clues to underlying valvular disease. So a non-pulsatile JVP is seen in the superior vena cava obstruction. Kussmaul sign describes the paradoxical rise in JVP during inspiration seen in constrictive pericarditis. So in constrictive pericarditis, that's what you see, Kussmaul sign. There's an increase in JVP during inspiration, and you need to remember this thing: Kussmaul constrictive. And during superior vena cava obstruction, a non-pulsatile JVP is seen. So in JVP, there are some types of waves that you have to remember. A wave is you have to remember that A wave is atrial contraction. It increases with large atrial pressure, of course. When can it happen? It's tricuspid stenosis, pulmonary stenosis, or pulmonary hypertension can cause it, and it's usually absent in atrial fibrillation. And Cannon wave, it can be caused by atrial contraction against a very closed tricuspid valve, or it can be also seen in complete heart block, ventricular tachycardia, ectopics, nodal rhythm, single chamber ventricular pacing. Okay, Cannon waves may be separated into regular and intermittent. So there are two types of Cannon waves. Regular is when there's ventricular tachycardia with 1:1 ventricular atrial conduction, and another one is AVNRT. We'll come back to that later. And irregular Cannon block is when there's complete heart block. Okay, C, you have to remember, is basically closure of tricuspid valve. So A is atrial contraction, C is closure of tricuspid valve. V is actually next to that is X descent. That is there's ventricular systole, fall in atrial pressure during ventricular systole. So when there's ventricular systole, that's when the pressure in atrium falls. So there's a descent in the curve. And then there's opening of the tricuspid valve, and also giant waves in tricuspid regurgitation. So all that. Next is heart sounds. Heart sounds is something we have been studying for a long time, and in MRCP it's also still an important topic. So what we need to know about heart sounds. First thing first, there are two heart sounds, S1 and S2 basically, and then 3 and 4 are also there, but S1 and S2 are the main ones. S1 is when the mitral valve and the tricuspid valves close, and S2 is when the aortic and the pulmonary valves close. So S1 is closure of you can see already here written, closure of mitral and tricuspid valves. It's soft when there is mitral regurgitation, and it's loud in mitral stenosis, and then it's end of opposite to what happens in aortic stenosis, and there is soft A2, but here it's loud in mitral stenosis and soft in mitral regurgitation. Variable intensity in complete heart block. Okay, S2 is caused by the closure of the aortic valve, closely followed by that of pulmonary valve. So A2 comes before P2. So causes of a loud S2 would be hypertension, loud A2, then pulmonary loud P2. So there's hypertension, and there can be loud second heart sound. Hyperdynamic states, atrial septal defect without pulmonary hypertension. Cause of a soft A2, as I was saying before, aortic stenosis causes a soft A2. Cause of a fixed split A2, atrial septal defect. So fixed split. Cause of a widely split A2 before P2, like the big gap between the two, can be because of deep inspiration. Right bundle branch block, so which means the right side of the heart won't be working well, and the left side will be quicker in contraction, and all the connections in the left side will be better. So A2 will be before P2. There will be a wide gap. Pulmonary stenosis can cause A2 to happen before P2. Severe mitral regurgitation can also cause that, and cause of a reversed paradoxical split, that is the pulmonary side closing before A2. Okay, that's left side not working well, like severe aortic stenosis, or left bundle branch block, right ventricular pacing, or WPW type B, that is external pathway in the right side, causing right side to be faster. Patent ductus arteriosus. Okay, there's another heart sound, S3, caused by diastolic filling of the ventricle. This is when the ventricle fills and there is a sound. Considered normal if less than 30-year-old, may persist up to 50-year-old for a woman. Heart in the left ventricular failure, constrictive pericarditis. And also very important, gallop rhythm. S3 is an early sign of LVF. S4 may be heard in aortic stenosis. It's very important. And HOCM, this is also important. Hypertension caused by atrial contraction against a stiff ventricle wall. In HOCM, a double apical impulse may be felt as a result of palpable S4. This is very important as well. Comes in MCQ. Okay, the next thing that comes up is the pulse. Slow rising pulse is aortic stenosis, because that's what the aorta leaves the heart, and then if there's stenosis, there will be slowing down of pulse. Jerky pulse is in HOCM, hyperobstructive. Jerky pulse is in HOCM, hypertrophic obstructive cardiomyopathy. And then there's this collapsing pulse, that's very much a feature of aortic regurgitation. It's also called the water hammer pulse. And this collapsing pulse also happens in pactor inductor ductus arteriosus, and hyperkinetic states like anemia, thyrotoxicity, fever, exercise, and pulses alternance, that is regular alternation of the force of the arterial pulse. There will be stronger pulse and followed by a weaker pulse, happens in severe LVF. Okay, pulsus paradoxus. This is not actually a pulse that can be felt. It is an abnormally large decrease in stroke volume, systolic blood pressure and pulse wave amplitude during inspiration. So during inspiration can happen rather than normal fall in systolic blood pressure during inspiration, faint or absent pulse in inspiration. Seen severe asthma and cardiac tamponade. These are the two places where this can happen. Okay, we're coming to ECGs now. Very important topic. Okay, ECGs. First thing first, incomplete ECG normal variants. What can be normal in an ECG? Incomplete right bundle branch block patterns with a normal QRS during duration are quite normal and common in healthy people. So RBBB that we talk about, it's quite normal in healthy people with a normal QRS. There's no evidence to suggest established RBB carries other than a normal prognosis. Compared to that, LVB is always pathological. That's something we have to remember. Isolated ventricular pause is less than 2 seconds during sleep. That's normal. Nocturnal bradycardia as low as 35. It's also normal. Ventricular ectopics commonly benign, but if more than 20% of total beats in 24 hours, could be associated with cardiomyopathy. So in an athlete, these things are normal, like sinus bradycardia, junctional rhythm, first degree heart block, Wenckebach phenomena. Okay, coming to a very important topic, that is left bundle branch block. Okay, criteria to diagnose a left bundle branch block on ECG. What can you see actually? Rhythm must be supraventricular in origin, so basically P wave should be present. It should be supraventricular, so P wave must be present. The QRS duration should be more than 120 meter per second, milliseconds, sorry, millisecond, 3 small squares, and there is RSR pattern. Okay, and since it's left bundle branch block, you will be seeing RSR pattern in V6. Okay, and there is this W pattern in V1. So there's a very good mnemonic to remember this whole thing. It's called William Marrow. So for William, you have to remember that there's double L in between, so left bundle branch block. W stands for the V1, W pattern in the V1, and in V6 there is this M pattern. So William and Marrow, that is M pattern in V1 and W pattern in V6. That's for right bundle branch block. Okay, what can be the cause of left bundle branch block? Ischemic heart disease, hypertension, cardiomyopathy, idiopathic fibrosis. Okay, what are the causes of ST depression? Okay, we'll be coming to more important and very important things. Okay, ST depression, can be normal if upsloping, ischemia, digoxin, hypokalemia syndrome X. So this is like a reverse stick sign, as they say, for digoxin, upsloping ST, horizontal ST. So ECG changes may be seen in hypothermia. In hypothermia, what are the changes you've seen in ECG? Bradycardia, J wave, small hump at the end of the QRS complex, first degree heart block, long QT interval, atrial and ventricular arrhythmias. J waves are seen in hypothermia, while delta waves are seen as shared with WPW. We are coming to that later on. Delta waves. Okay, so what are the features of an ECG in digoxin when a person is having digoxin? This, as we've said before, downsloping ST or reverse stick sign, flattened or inverted Q waves, short QT interval, arrhythmia, AV block, bradycardia. These are the things that you can see. Okay, what are the causes of prolonged PR interval? Normal PR interval, as you know, is 3 to 5 small squares, and PR more than 5 small squares, one first degree heart block. So it's normal in athletes and elderlies. Patient with ischemic heart disease can have PR prolonged interval, hypokalemia, aortic root pathology like abscess secondary to endocarditis, idiopathic Lyme disease, digoxin toxicity, sarcoidosis, myotonic dystrophy, rheumatic fever. All these can cause prolonged PR interval. Coming to axis deviation, what are the causes of left axis deviation? Basically, left anterior hemiblock can cause a left axis deviation. Left bundle branch block can cause a left axis deviation. And then comes the WBW syndrome, that is right sided accessory pathway. So right side works more, left axis deviation. Hyperkalemia can cause that. Congenital ostium primum, ASD, tricuspid pressure, and minor LAD in obese people. Now, how do you know, if it's left axis deviation? You see that in lead 1 in ECG there'll be positive QRS, and lead 3 AVF will see negative. So that's when that's LAD. That's you'll understand. Is deviation of axis in the left, towards the left, and for right axis deviation, that is like towards the right. The axis is deviated towards the right. So in lead 1 you will see negative, and in AVF you will see positive. What happens in right axis deviation, or the causes of it? Right ventricular hypertrophy, left posterior hemiblock, chronic lung disease, pulmonary embolism, ostium secundum, and WBWA syndrome, left-sided axillary pathway, causing it to move towards the right. Normally in infant of less than 1 year old, minor are 18 tall people. Okay, general cardiology, things that you need to know. Isolated systolic hypertension. What is it? It's common in the elderly, affecting around 10% of the people older than 70. The systolic hypertension in the elderly people. Okay, whatever. This is just some additional information that you don't need to know. So hypertension management guidelines, that's very important. NICE 2019. They've said if clinic BP is more than 140/90 in 2 readings, offer ambulatory blood pressure monitoring to confirm the diagnosis. Okay, what are the stages are there for the hypertension? Stage 1, clinic BP more than 140/90 and subsequent ABPM, daytime average or home monitoring average more than 135/85. That's stage 1. Stage 2 is BP 160/100, more than that, and subsequent ABP, that's the average is more than 150/95. And severe hypertension, clinical systolic more than 180, diastolic more than 110. That's severe. What are the treatments that you offer for hypertension? So the treatment for hypertension, firstly, lifestyle advice should be offered. Initially, offer antihypertensive drug treatment to people less than 80 years with stage 1 hypertension who have one or more of the following. So if they have people less than 80 years old with stage 1 hypertension with one of the following, you have to offer antihypertensive drug. What are the things? Target organ damage, established cardiovascular disease, renal disease, diabetes, or 10-year cardiovascular risk more than 20%. What are the steps? Firstly, step 1, patient less than 55 years old, what do you offer? You offer ACE inhibitor or low-cost ARB. Patient with more than 55 years old with or Afro-Caribbean origin, you offer a calcium channel blocker or thiazide-like diuretic like indapamide. The target BP is 140/90 in for people less than 80 years. More than 150, as in more than 80 years old, your target is 150/90. Step 2 is step 1 plus. This one, step 1 plus add a calcium channel blocker or a thiazide-like diuretic. Okay, for Afro-Caribbean, step 1 plus ARB, reference to ACE inhibitor. So step 3 is combination of ACE inhibitor, ARB plus calcium channel blocker. ACE inhibitor or ARB plus calcium channel blocker plus thiazide-like diuretic should be used. Step 4, consider seeking experts' advice, and of course consider further diuretic therapy with low dose spironolactone can be used. If potassium is less than 4.5, as you know, spironolactone will definitely increase the level of potassium in the blood. Or high dose thiazide-like diuretic if potassium is more than 4.5, so you can't give spironolactone in this case. So just increase the dose of of thiazide-like diuretic. Monitor sodium and potassium. Spironolactone is an aldosterone antagonist and it increases potassium in the blood, if you know. If the above is not tolerated, consider alpha or beta blocker. Okay, beta blockers are less likely to prevent stroke, plus potential impairment of glucose tolerance. This was demonstrated in the Anglo-Scandinavian cardiac outcomes, whatever. Okay, what are the causes of secondary hypertension? We know the major cause is basically 80% of renal is accounting for 80% of the secondary hypertension causes, like glomerulonephritis, pyelonephritis, PKD, renal artery stenosis, and other secondary causes can be endocrine disorders like Cushing syndrome, primary hyperaldosteronism like Cone syndrome, Little syndrome, congenital adrenal hyperplasia, pheochromocytoma, acromegaly, others like pregnancy, coarctation of the aorta, combined oral contraceptive pill, steroids. and also monoamine oxidase inhibitor antidepressants. For people with less than 40 years age with stage 1 hypertension with no evidence of target organ damage, cardiovascular renal disease or diabetes, consider seeking specialist evaluation of secondary causes. So if there is no danger signs, you look for the secondary causes and a more detailed assessment of potential target organ damage. This is because 10-year cardiovascular risk assessments can underestimate the lifetime risk of cardiovascular event in these people. Okay, one of the other things that you can actually give for hypertension, direct renin inhibitors like alisquiren. By inhibiting renin, blocks the conversion of tensinogen to angiotensin 1. So it's basically blocking renin production. So no trials have looked at model data yet, and this is just about about alisquiren. Adverse effects are uncommon. Only diarrhea is seen. Only current role would seem to be the patient who are intolerant of can be given with ACE inhibitor or ARB when eGFR is less than 60 or in diabetics. So with renal impairment, you can't be giving direct renin inhibitor. Some examples of centrally acting antihypertensives are here: that methyldopa is in the management of hypertension during pregnancy, moxonidine used in the management of essential hypertension when conventional and antihypertensives have failed to control blood pressure. Clonidine can be given. The antihypertensive effect is mediated through stimulating at A2 adrenoreceptor in the vasomotor center. Diabetes is an added cardiovascular risk factor for hypertension and should therefore be actively looked for and treated. It is also a risk factor for development of diabetic nephropathy. So the selected points, the BP of our diabetes is 140/80 target for BP for diabetic people. So 140/80. If there is end organ damage, the target is 130/80. ACE inhibitors are the first line for diabetic people. Okay, it also increases insulin sensitivity and can therefore be useful and can therefore theoretically cause hypoglycemia as well. So BNF advised to avoid the routine use of beta blockers in uncomplicated hypertension, particularly when given in combination with thiazides, as this may cause insulin resistance, impair insulin secretion, and alter the autonomic response to hypoglycemia. So beta blockers better not be used in diabetics. Okay, so DVLA, a lot of questions come about how many weeks should be taken off, and it's like a 2018 update. So what we go to this place directly instead of reading it too much. So people with angina must not drive while symptomatic. Angioplasty, just 1 week off driving, 1 week for angioplasty. CABG, 4 weeks, it's a big operation, 4 weeks. Acute coronary syndrome, it's a big event, 4 weeks off driving, 1 week if successfully treated by angioplasty. So angioplasty, 1 week. Pacemaker insertion is 1 week off driving. Implantable cardio defibrillator, if implanted for sustained ventricular arrhythmia, cease driving for 6 months. That's a long time. If implanted prophylactically, then cease for 1 month. Successful catheter ablation, 2 days of driving. This is the shortest, I think. Aortic aneurysm more than 6 cm, notify DVLA. Licensings will be permitted subject to annual review. An aortic diameter of more than 6.5 or more disqualifies people from driving. So this is the worst case. Heart transplant, no driving for 6 weeks after surgery. Doesn't need to notify DVLA. Long QT and Brugada syndrome must notify DVLA. Why? License will be refused or revoked. Relicensing will be considered upon appropriate specialist assessment, because long QT may turn into something worse, like a VT. Okay, we're coming to cardiac imaging and investigations. Nuclear imaging. What are the things that you can see in the heart with the imaging and everything? Nuclear imaging, these techniques are used radio tracers, of course, which are extracted by normal cardium. What are the tracers? Thallium. Then there's MIBI or SPECT scans, cardiac single photon emission computer CT. That is, CT uses technetium. System may be a coordination complex of the radioisotope technetium with the ligand MIBI. PET scans uses FDG, fluorodeoxyglucose. So thallium, technetium, deoxyglucose is used. The primary role of SPECT, this one, is to assess myocardial perfusion, like how much blood is going in and coming out, if it's enough supply of blood, and myocardial viability, the condition of the muscles. 2 sets of images are usually acquired. First, the myocardium at rest, followed by images of the myocardium during stress. So during stress and during rest, how the perfusion is going on. By comparing the rest with stress images, any area of ischemia can be classified as reversible or fixed. Following a myocardial infarction, cardiac PET is predominantly a research tool at the current time. So SPECT is the one where we use technetium. This is the one to check perfusion. MUGA, multicated acquisition scan, also known as radionuclide angiography. Radionuclide technetium 99 mm is injected intravenously. The patient is placed under a gamma camera, may be performed as a stress test, can accurately measure left ventricular ejection fraction. Typically used before and after cardiotoxic drugs are used. Okay, the main thing about MUGA is this mentioning, like measuring the left ventricular ejection fraction, but we also check it in echocardiogram. CT, cardiac CT, useful for assessing suspected IHD using two main methods: calcium score and contrast enhanced CT. So what you do is there's known to be a correlation between the amount of atherosclerotic plaque calcium and the risk of future ischemic events. So what you see is like how much calcium is there. Cardiac CT can quantify the amount of calcium, producing a calcium score. And contrast enhanced CT allows visualization of the coronary artery lumen. Okay, so these two techniques are combined. Cardiac CT has a very high negative predictive value for ischemic heart disease. So we need to know what imaging are useful. Cardiac MRI now. That's next. CMR, that's what we call it, has become the gold standard for providing structural image of the heart. It's particularly useful when assessing congenital heart disease, determining right and left ventricular mass, and differentiating forms of cardiomyopathy. So it's very important. Myocardial perfusion can also be assessed following the administration of gadolinium, but previously we've seen like what we use for perfusion thing is SPECT. Okay, so currently CMR provides limited data on the extent of coronary artery disease. Exercise ECG not a diagnostic tool for ischemic heart disease anymore. Currently used to quantify symptoms during heart exercise in non-IHD. So useless in patient, this exercise EEG, useless for what? Patients with conduction abnormality, resting ECG abnormalities like ST segment depression of more than 1 millimeter, WPW decoxing, ventricular pace rhythm. Next we go towards heart failure.